Yes, they are.
Yes, Meenakshi,
Yes, they
yes.
are.
Go ahead.
Okay. So today's topic of discussion would be, PCOS and hyperglycemia in pregnancy, case-based discussion. So I wouldn't go too much into the theory, but definitely I need to give a small intro before I move into the cases. So as everybody is aware that whenever we talk of PCOS, one only thinks of acne or hirsutism or the ultrasound findings talking of PCOS, but there's something beyond it also. And we need to understand that unfortunately, the prevalence of PCOS is as high as 19.6% in the adolescent population in comparison to the women population. And there is a diagnostic criteria based on which one could confirm the diagnosis of PCOS than just looking at hirsutism or acne. So we have, out of the 3 findings, you have to have at least 2 positive findings in order to confirm and say that this patient is particularly having PCOS. So it could be either hyperandrogenism, which means there is a raise in the testosterone level, or there could be a moderate borderline raise in the DHEA, or there could be an ovulatory dysfunction or polycystic ovaries. Among these 3, you should have at least 2 for you to confirm PCOS. So obviously you are looking at this slide, which also looks at acanthosis nigricans, which is nothing but a velvety nape of the neck. If you can look at the picture on the left hand side, you can see a lady with the nape of the neck having a dark velvety skin, which is a marker of insulin resistance. And on the right side, you can see acne. So now you need to understand that there are 4 important risk factors towards moving towards PCOS. PCOS, you could have either hirsutism and acne as a clinical feature, or you can have either oligo-ovulation or anovulation, meaning you may not actually ovulate at all. If it is a lady and she is married, then we can expect also infertility or subfertility. Metabolic features could be a raise in fasting serum insulin assay, or there could be pre-diabetes, diabetes, a dip in the HDL, a raise in the TGL, or also there could be other parameters like a raise in the physiological index, that is the blood pressure. So all these are the metabolic features. Now, what are the risk factors in order to pick up a PCOS is? You could have environmental toxins. Yes. You could have environmental toxins like endocrine disruptors, which in turn cause an imbalance either in the luteinizing hormone or the follicle stimulating hormone. And as the term itself, anovulation or oligo-ovulation talks itself, you can understand that there could be a dip in the follicle stimulating hormone. Similarly, when it comes to hyperandrogenism, I think it relates very, very clearly that there is an increase in testosterone. Hence, you could see facial hair on the thighs, hair on the chest. All these things are also markers of hyperandrogenism. Insulin resistance, I've already made a mention. Now look at it could be hereditary. It could be most commonly because of gut dysbiosis. There is a relationship of gut dysbiosis and hyperandrogenism, increase in the testosterone levels. Obviously, diet plays an important role with reference to insulin resistance, and one can talk that whether it's hyperuricemia, skin tags, acanthosis nigricans, or PCOS, they are all markers of insulin resistance. So where the role of low GI and low GL foods plays a very, very important role. Now, this is an important term which usually goes hand in hand with PCOS. That's the dogma theory, which is nothing but dysbiosis of the gut microbiota, which I made a mention to you previously itself, that it could cause hyperandrogenism, menstrual irregularity, as well as anovulation. Now, I would want to deep dive into a case straight shot here. So in this particular case, this was a 20-year-old female with a raised BMI, and she had PCOS, hypothyroidism, irregular menstrual cycle. Now she was put on a WhatsApp keto diet, wherein she was consuming less than 50 grams of carbs. If you look at her diet pattern, it had negative calorie vegetables like onion, capsicum. It had MCT in the form of coconut oil, though coconut oil has only about 66% of MCT, but it's a source of saturated fat. She was consuming fish fingers, tea with very minimal sugars, the gourd varieties and the cabbage varieties. Gourd was obviously cooked. Cabbage was in the form of a raw salad, which you need to remember that she's a hypothyroid, so she was still consuming raw cabbages. She was consuming whole eggs, which is a source of saturated fat, which can in turn cause gut dysbiosis. 35 grams of butter, which is again a source of saturated fat, which in turn can cause gut dysbiosis. And green tea, yes, we understand there is some evidence which I'll go a little further down to tell you what are the benefits of green tea. But remember, she's hypothyroidism and she was consuming green tea, which is not usually permitted. Now, what really happened to her? she lost almost 12 kgs of weight in 1 year following this particular diet. And believe me, I think as nutritionists, you are very well aware that you can easily break down the weight loss of 12 kgs in 3 to 4 months without even following a keto diet or a pseudo paleo diet or a pseudo keto diet. Simple reduction of 500 calories from present intake and stepping up physical activity by 35 to 45 minutes per day for 5 times a week at least, you can easily bring down 1 kg of weight per week. It's an easy bet. But she chose something like this. So what really happened? She lost those 12 kgs and beyond a particular point, she could not follow this particular diet. As soon as she stopped this diet, she started gaining weight of 3 kgs in 2 months. Her triglycerides were skyrocketing. Her LDL was raised. Her TSH also was raised. The reason being she was consuming some goitrogens in the form of green tea as well as cabbage. And apart from that, she started having a regular cycle. So her thought process was her PCOS needs to be corrected. And there is some evidence which I will share with you in the future slides that how a ketogenic diet helps to regulate PCOS and why she fell prey to this. Now, but what really happened end of the day, she started having spotting and finally she stopped having her menstrual cycle. Now, this is very, very shocking. A 20-year-old girl stopped having her menstrual cycle after being put on a KD diet. And most unfortunately, this is known as the athletic triad, wherein in few patients who follow a particular diet like this, with low carbs, less than 50 grams, they land up with amenorrhea. So we move to the next case. Understanding this case, she had some queries. What were the queries? She knows that a plant-based diet is healthy, but alongside she felt that fish is also healthy. It's a rich source of omega-3 fatty acids, it's anti-inflammatory. Why shouldn't I still continue consuming fish? And if I'm consuming it in an air fryer, why not? Now remember one thing with fish, especially when it comes to fish finger, it is prepared from basa fish. Who is aware of the culinary skills with reference to fish finger? It travels several thousands of kilometers and it is preserved. That is the second thing. Now, so when we talk of fish, we do understand that they are endocrine disruptors unless and until the fish is from freshwater fish or lake water or pond water fish. Now, next thing was she said she's using an air fryer for preparing the fish finger. So air fryers are available in two different forms. You have the non-food grade material, which is also found in the economical air fryers. So that is also another source of endocrine disruption. She had another question. Does milk worsen her acne? We have practical experience with PCOS patients consuming milk and milk products and seeing acne the very second day and third day. There is also some evidence to talk about cheese being good for PCOS, which I'll deep dive in the next few slides. Now, green tea helps in weight loss. Yes, it increases the BMR and helps in improving weight loss. Helps to reduce the testosterone levels, but was it the right thing in her case? How useful is KD? And what about choosing on artificial sweeteners in comparison to sugar? So that also causes gut dysbiosis. Now, if you look at bisphenol A, which is an endocrine disruptor, there is some study and data to tell us that when you measure the bisphenol A values in the serum of PCOS patients, the bisphenol A values are very, very high. Apart from that, they also see the testosterone being really high. So we understand that when there is endocrine disruption due to certain environmental factors, like it could be also, non-food grade plastic, it could be cosmetics, it could be insecticides, pesticides, it could be preservatives, a host of additives which can add to increase in the bisphenol A, which has a direct relationship with PCOS. So that is the first thing which we need to understand. Second thing is dairy intake. Now, I would want to make a mention here is there is a lot of conflicting data with reference to dairy intake. We do understand whether you consume skimmed milk or whole milk. Dairy intake stimulates insulin growth factor 1, IGF-1, resulting in high insulin levels, but this does not happen with cheese products. Cheese products basically contain ruminant fats. Ruminant trans fats are also present. There was till 2018 data to tell us that it contains trans fats, which are ruminant trans fats, so it's absolutely safe to eat. It is not going to cause any gut dysbiosis or any ill health or metabolic issues to an individual. But in recent data, 2019, 2020, 2021, the American Heart Association Presidential Advisory Guidelines very clearly tells us that even the ruminant fats, whether it's present in red meat or cheese, are sources of trans fats, which in turn cause metabolic disturbances. So we have some data with that. Second thing is we also have some data which tells us that milk does increase the insulin-like growth factor, but also increases dihydrotestosterone, which increases the androgens, resulting in high sebum production and acne. So basically, milk per se is going to definitely increase your DHT as well as acne. So beware of it. But the data involved here is very, very sparse. Now, with reference to cheese, there is some data with reference to only 24 women, which tells us that when you consume an ounce of cheese and you eliminate all the starches and choose on low calorie foods, it does improve insulin sensitivity because it is low in GI, low in GL. Obviously, anything with fat and protein will have a low GN and low GL. But on the other hand, we also have some data to tell us that whole milk as well as fat-rich dairy products have a high estrogen concentration, low level of androgen. Estrogen can decrease the levels of insulin-like growth factor. But whatever said and done, we understand that cheese is a source of saturated fat, which in turn can cause gut dysbiosis, which in turn is a risk factor for PCOS. So what about sugar-free? I'll come to it a little later. This was some data with reference to green tea, which does tell us that it can improve weight loss, decrease fasting insulin, decrease in level of free testosterone. But remember that it cannot be consumed by hypothyroidism, and you cannot consume it in those people who have iron deficiency anemia. You have to space the green tea with the iron so that you don't land up with iron deficiency anemia. I'll talk to you about why I'm talking about iron deficiency anemia a little later on. The third important thing is it decreases the level of free testosterone, which is good for a PCOS. But remember, the upper limit is only 300 ml per day. So now, as I was making a mention, can somebody just mute their mic, please? I can hear some disturbance.
Sumana,
the back team kindly mute all others and only the speaker.
So we also have some data to tell us that you can have some calcium and vitamin D supplementation, which improves hirsutism, testosterone. A low GI diet reduces fasting insulin, total testosterone, and also helps to improve the sex hormone binding globulin synthesis. So all this can be improved by vitamin D and calcium supplementation. Obviously, we do understand vitamin D. It's like a hype or reality. I'm yet to be very, very clear with it because we see almost PCOS, non-PCOS, type 2 DM, obese, lean, anybody and everybody with vitamin D deficiency. Obviously, we need to expose 18% of our body, that is only our arms, we will get the total vitamin D required. But there is some conflicting data. Even the farmers who are exposed to sunlight, they are also vitamin D deficient. But anyway, that's the second part of it. But second important thing is fermentable fiber, like the prebiotics has an important role in releasing the short chain fatty acids, which in turn help to improve gut health. Now, KD, as I mentioned to you, this ketogenic diet, there is some data to tell us that it does help to improve testosterone, dihydroestrogen, androgens, DHEA. But remember that this particular data was only with very few subjects. Very, very few subjects. I think they were only about 14 subjects. They were followed for 12 weeks. They were provided almost as high as 132 grams of fat, 100 grams of protein. And imagine the number of subjects were only 14 subjects. So I don't think we don't have any RCT to tell us, but yes, if you follow a plant-based ketogenic diet, and is it sustainable? I really wonder if it is a sustainable option for one to choose on it. But definitely, if you're going to choose only on a ketogenic diet, which is a non-vegetarian ketogenic diet, definitely it is going to lead to gut dysbiosis. So that's not going to help our PCOS patients. So don't go with just the paper. You know, this paper was actually published in a major journal and a recent 2020. But you need to deep dive inside to see what actually is the data. We have another case here. This is a 19-year-old female with documented PCOS, and she has everything, you know, menorrhagia, hirsutism, acne, altered menstrual cycle. She's also a part of part-time fashion influencer and a makeup artist.
Join it.
So remember, you know, we've always seen PCOS with insulin resistance and an increased BMI. But look at this case. She's a lean PCOS with a BMI of only 15 kg per meter squared. She has anemia, and it is documented that she has hypochromic microcytic anemia, which is iron deficiency anemia. She has a borderline testosterone. She has DHEA. She has mild acne. She's a vegetarian. She avoids milk and milk products. She's known to skip breakfast. And why does she skip breakfast? she feels shy to carry a dabba with her, or if she leaves to college, she gets up late. So she feels very shy to carry a box of breakfast. And she says, why do I carry a box of breakfast? Nobody carries a steel dabba to college these days. We prefer to sit down with the friends and eat in the college canteen. And what do you eat in the college canteen? Either it's a puff or a samosa, or, and when she comes back home, she skips her lunch. She has dinners delivery from food delivery apps. So she's consuming a lot of ultra processed foods, which in turn are sources of saturated fat, trans fat, and sodium. I want to make a mention here of sodium here also. So here in her case, the bisphenol A are coming from the cosmetics. Why from cosmetics? Because she's a makeup artist. So she tries a lot of makeup on herself before she does it on the artist. And it is an important thing which increases her bisphenol A. Next is she consumes a lot of ultra processed foods and consumes outside food a lot, which is rich in sodium. And for your information, the recent data did make a mention that the salt which is available from the sea, which you and me consume, may contain microplastics, which in turn are endocrine disruptors. The third thing is she picks up food from food delivery apps, which again contain a lot of saturated trans fat, sodium, a lot of preservatives, colors, additives, which in turn can cause gut dysbiosis. So in her case, she needs to cut down on eating out as much as possible and go home based and probably wear some gloves or something and not to try the makeup on herself. So the corrective measures in her case will be most importantly to correct her iron deficiency anemia. Look at her BMI was only 15. And there is some paper to tell us that iron deficiency anemia is also a marker of insulin resistance, which can in turn further cause PCOS. That was one of the causes in her case, apart from her makeup, which is an endocrine disruptor. So in her case, we need to work as nutritionists. I'm sure you are aware how we can work on her dietary intervention. Then second thing about it is spirulina as an important role here. We've seen that she is vegetarian and she does not consume milk and milk products. So we require also B12, which will come from the spirulina. And also there is some paper to tell us that if you consume 6 tablets of spirulina through the day, it helps in improve the PCOS. The third thing is green tea is great to go. It helps to improve her testosterone levels. Space green tea with iron-rich foods because she's already documented iron deficiency anemia. Follow a DASH diet. That is, you need to follow home-cooked food and not processed foods. Seed cycling in her case will really help. I'll go a little more later on the seed cycling. And there is some data to tell us that sunlight exposure for vitamin D. She's a vegetarian, so we cannot consume fish oil, though there is data for fish oil. Vitamin B12 supplementation or spirulina, myo-inositol, and dietary lifestyle modification to correct her gut dysbiosis and decrease her exposure to cosmetics. Now, this is the data with reference to spirulina. I'll not deep dive too much into this, but just to have an idea that how it works on the hormones and helps to improve PCOS. This is recent 2022 data. This I made a mention to you that salt is a source of microplastics and so do the ultra processed foods, which are a source of sodium. So this is some paper to tell us that when you consume a dietary approach to stop hypertension, that choose only home cooked foods with less sodium rich foods or less of ultra processed foods or processed foods or packaged foods, you can improve PCOS. And this is the paper on endocrine disruptors, which I did make a mention that personal care products are a source of endocrine disruption. This is a paper which talks how we can improve gut microbiota by probiotics and prebiotics. I would make a mention here that choose on prebiotics like onion, garlic, leeks, oats. All these things are prebiotics which help to synthesize probiotics. Now, there is another term called combination of pre and pro is symbiotic. And we also have the postbiotic. Postbiotic is those foods which are rich in probiotics when they are cooked. Obviously, the probiotic nature is lost, but the metabolites which are formed behave like postbiotics, which also have an important role to strengthen your gut health. So this is a slide on seed cycling. As a dietitian, we should have evidence whenever we choose on certain additives in our diet. Without having evidence, please do not choose on anything. So there is a lot of evidence here to talk about seed cycling for hormonal balance. From day 1 to day 14, you can choose on 1 tablespoon of flax seeds and 1 tablespoon of pumpkin seeds. Now, I'm not going to go into the details how it is going to do its job because of paucity of time. I need to move on to GDM also. So just understand that 1 to 14 days, you can give 1 tablespoon of flaxseed, 1 tablespoon of pumpkin seeds, Day 15 to day 28, 1 tablespoon of sunflower seeds and 1 tablespoon of sesame seeds. Along with that, supportive oil like fish oil, which wherein we have enough data for it, also the evening primrose oil. All these together do their job in order to improve their, menstrual cycle. But remember, when you are having hypothyroidism, which is very, very common with PCOS, you cannot provide flax seeds because they are goitrogenic in nature. Now coming to case 3, this I'll quickly wind up because we need to move forward. We have a 31-year-old female with PCOS. She has got psoriasis with PCOS. She has got gastritis and a raise in the TGL, hyperuricemia with acanthosis nigricans, irregular menstrual cycle, acne, hirsutism, hypothyroidism. You can call for her and she has all of it. Here also, she is having lactose intolerance and vitamin B12 deficiency. She's got pre-diabetes, and there is recent information for us from the ADA, which tells us that you can put patients on pre-diabetes with metformin once a day, at least to start off with, in order to correct their insulin resistance, which can in turn help to improve the PCOS. So they are on, this patient is already on nutritional supplements like coenzyme Q10, myoinositol, L-troxin, and there is some information extra apart from her height, weight, waist-hip ratio. We have the neck circumference. Now, recent data tells us, that is reproductive endocrinology 2021 data tells us that there is insulin resistance which is directly proportional to neck circumference in PCOS women. So we need the neck circumference in women less than 34 centimeters. In her case, it is 38. She has a HbA1c of 6%, which just tells us that she is a pre-diabetic, hyperuricemia, which tells us that she needs to be off non-vegetarian food sources, as well as endosperms. When I say endosperm, that is the whole grams. The whole grams, unless they are sprouted, they should not be consumed. If they're consumed directly without sprouting, they are going to contain the intact endosperms. The third thing is TGL is raised. So this very clearly tells us that she is consuming more fat in her diet. Second thing is more carbohydrate, more simple carbohydrate. And the type of fat what she's consuming is unhealthy fat. That is why there is an increase in her TGL, though she has not made a mention to us about her alcohol consumption. Maybe if there is alcohol consumption also, that could be a reason for a raise in TGL. So we need to correct our entire metabolic health by suggesting weight loss at least 7 to 10% so that we correct her pre-diabetes. When we correct her pre-diabetes, bring down her insulin resistance, and put her on a purine restricted diet along with weight loss, her uric acid will come down, her TGL automatically will come down, her neck circumference will improve if she indulges in physical activity, the ideal physical activity. I am not the right person for that, but an ideal physical activity to correct her neck circumference. Apart from that, what else can we do? We cannot put her on green tea or flax seeds or seed cycling because she's got hypothyroidism. So that cannot be done. We need to correct her vitamin B12 deficiency in case she is anemic. Now, this was her diet which she was consuming. If you look at all the red color portions, they are all the unhealthy foods or the high GI, high GL foods, which in turn are the reason for her insulin resistance. So what are the corrective measures in her case? She needs to go plant-based, soft cooked, small and frequent bland. Why? Because she has got gastritis. So in her case, what I did was I gave her a diet for about 1 to 2 weeks, settle her gastritis, and then work on her psoriasis, and third to work on her PCOS. I did not jump into her PCOS straight shot. First was gastritis, then find out the trigger factors for psoriasis, correct her pre-diabetes along with her PCOS together. So in her case, she was found to have excess wheat and excess sugar in her diet, gave severe itching and in her scalp and shedding of scales. So we found that she was sensitive to gluten and lactose. We had to put her on gluten and lactose free diet, purine restricted diet for her hyperuricemia. Carbohydrate, fat, protein, we had to adjust it and bring it down to a minimum, not to a minimum which is not sustainable. So in her case, we could bring it down to 50 to 55% carbs, 25% fat, 20 to 25% protein. We couldn't go beyond this because she could not consume more than 75 grams of protein per day in practical basis. So low fat curds, low GI, low GL. But in such patients, usually when they come to me with pre-diabetes and PCOS, I usually replace one meal with a low GI, low GL oral nutrition supplement. But in her case, I needed to choose on a lactose-free, high protein, healthy fat oral nutrition supplement so that I could ease off in her weight loss pattern. So another thing was we need to think of spirulina in her case, continue nutritional supplement, choose on vitamin D fortified oil, but the amount of vitamin D provides only 7% of your RDA. So you cannot rely only on vitamin D fortified oil. Exposure to sunlight, if still not corrected with adequate vitamin D. DASH diet, yes, avoid goitrogenic foods like, especially when we talk of millets when you are gluten free. You need to remember that pearl millet like bajra, even when it is fermented, it still remains to be goitrogenic. Apart from that, we have the unprocessed millets. That is the other millets like, the barnyard millet is one millet, which is really good when it comes to GI, GL, fiber. But it needs to be either sprouted, fermented, or roasted prior to consumption in a patient like where I want to push weight loss and improve our blood glucose levels. I should remember to use only processed millets and keep away from bajra, that is pearl millet. Green tea in her case, I would have to avoid seed cycling. I cannot do. Regular physical activity is a must. So I am now going to move on to, before I move on to GDM, I would want to show 1 or 2 slides of nutrition strategies which would really help a PCOS patient. She needs to lose weight. She needs to choose a low GI, low GL, modify a carbohydrate to a lente carbohydrate, which I'll talk to you a little later on. Modify the fat to healthy fats and proteins, which are lean proteins or plant-based proteins, basically. So there is some paper to tell us that a low-calorie diet in about 100 PCOS patients with 5 small meals, 25% protein and fat, 50% carbs, if it is sustainable for you to choose on 50% carbs, choose on that. Otherwise, go 50 to 55, not more than 55, and try to achieve at least 30% from complex carbohydrates. Include, freshwater fish, green tea, low-fat dairy, which indicates that there is a loss of 7%, which corrects your insulin resistance. And in this particular paper, they found that CRP were reduced by 35% and 63% of the women regained menstrual cyclicity just by following this anti-inflammatory diet. Alongside, supplement with N-acetylcysteine, which we would have heard commonly used in patients who are going in for an, angio, wherein we put NAC for those patients in order to prevent AKI. The same concept here is you need to put them on NAC, that is N-acetylcysteine, in order to improve PCOS. But this alone will not work. It has to work with combination of diet and physical activity. Then myo-inositol, vitamin D, fish oil, and vitamin B12 supplementation. So now I move on to the next important segment is those patients who have PCOS and they correct themselves, they go for follicle stimulation and stuff like that when there is infertility. Unfortunately, they walk into gestational diabetes. Now, when I'm talking of hyperglycemia during pregnancy, I'm not talking only of gestational diabetes. I'm talking of gestational diabetes. I'm talking of type 1 diabetes walking into pregnancy. I'm walking into type 2 diabetes walking into pregnancy. I'm talking of pre-diabetes walking into pregnancy. So all of them come under hyperglycemia during pregnancy. Remember that whenever you diagnose GDM, you're actually having a window of opportunity to prevent transgenerational risk of non-communicable diseases. One of them is diabetes, that is type 2 diabetes. So maternal hyperglycemia is associated with development of metabolic problems in offspring. I would want to make a mention here of 2 things. We only think of the male, not the male child, the female child when it comes to transgenerational risk of diabetes. If it is a female who is GDM or she's pregnancy with hyperglycemia, if she's not going to have good blood sugar control, she is going to deliver a macrosomic baby. A macrosomic baby is large for gestational age, which will be born insulin resistant, meaning there is going to be a lot of visceral fat around the main organs, which is going to induce insulin resistance. And when the child is a female child, she is going to grow up with already existing insulin resistance. She is going to be at risk of PCOS, and then she's going to conceive and GDM, and then the cycle goes on. Now, second concept is if the mother is undernourished, like we had one of the females who had iron deficiency anemia with 15 kg BMI. Suppose the mother is 15 kg BMI, no PCOS, and she continues her pregnancy with a very, very low BMI. She's going to deliver a low birth weight infant. This low birth weight infant is going to have fewer nephrons, fewer neurons, fewer beta cells, and she's again going to be delivering a child who's going to be at risk of type 2 diabetes as well as other NCDs. Now, the important crunch point here is if the mother is going to deliver a male child with poor blood sugar control, that male child is going to be at a very, very high risk of infertility, which is some recent data. So now we move on to the case studies, and wherein I will, the connect the case studies with the evidence-based guidelines. So we have a GDM mother here who was typically diagnosed in the second trimester of her pregnancy. And when she came to us, she had, before we deep dive into looking at her values, we need to understand that there are several criteria, to understand that what should be the fasting blood glucose, what should be the postprandial blood glucose. We have the ADA, we have the WHO, the HAPO, IDF, so many DIPSI guidelines. But more often, most of these guidelines are between 92 and 95. You keep the cutoff as less than 90 milligrams of blood glucose as your fasting cutoff. And postprandial should be less than 120 milligrams. And 7-point glycemic profile. When I say 7-point glycemic profile, pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and a 3 a.m. blood sugar. All these 7 blood sugars, when I add it and divide it by 7, this average blood glucose should not cross 105 milligrams. Now, these are the numbers which you need to stick into your head. A type 2 DM patient and a GDM or a pregnancy with hyperglycemia, their cutoffs are different. We expect a cutoff of less than 126 in a type 2 DM patient. But in somebody with hyperglycemia and pregnancy, we want the fasting less than 90, postprandial less than 120. I will go into the time in range a little later on. Now, in this case, she was a classical GDM who was diagnosed in the second trimester. Her post-breakfast was 110, fasting was 88, pre-lunch 90, post-lunch 155, pre-dinner 80, post-dinner 160. So in her case, we are finding the post-lunch is raised, post-dinner is raised, her OGTT was done, and in her OGTT with 75 grams of glucose, they found that she was at risk of developing gestational diabetes during her pregnancy. So she was under care and monitoring, and under care and monitoring, they found 2 values raised. As soon as the 2 values are raised, they will jump into meal plan therapy. That is universal screening as per DIPSI guidelines or Ministry of Health. After you have done the screening, you need to jump into medical nutrition therapy. Classically, they wait for 2 weeks as per theory, but in real-time practice, they do not wait very, very long. If the fasting is more than 90, they do not wait to initiate insulin. In this case, the fasting thankfully did not cross 90. So they wanted to give some time to wait and watch for at least a period of 2 weeks. Did she improve with meal plan therapy? Now, what was her BMI? Her BMI was 18. So normal BMI, no need to worry. In case of a female, there is some recent data to tell us that we need to follow something called a divine formula, which is specific to gender. Now, all this while, we've been following some formulas which we've been hearing from our seniors and senior dietitians in our hospitals that follow this height minus 100 into 0.9 for male, height minus 105 for female. If you're a diabetic, height minus 100 into 0.8 for female, but we don't have evidence for it. So when we deep dive and found out that there is some evidence to tell us for gender specific formula, we came to the divine formula which said for a female 45.5 plus 2.3 kgs into every inch above 5 feet, we get a value. After that, we reduce 10%. Why are we reducing 10%? If this lady was a type 1 walking into pregnancy, we are not worried about insulin resistance. She is a lady who's classically been identified as GDM during a second trimester, which means there is carbohydrate intolerance, there is insulin resistance. So we need to bring down the insulin resistance. We need to reduce 10% from whatever number we get. And finally, we've got a number of 52 as our ideal body weight. Her pre-pregnancy weight and our IBW both are 52, so we don't have to worry as much. So now what are we going to do? What is my goal for my GDM mother? My goal is she should achieve ideal weight throughout her pregnancy. What is her ideal weight? Between 8 to 12 kgs is her ideal weight. I would say between 10 to 12 kgs. Now, depending on what her pre-pregnancy BMI was, will be her ideal weight gain throughout her pregnancy. Second is there should be maternal and fetal well-being, achieve normoglycemia. It's important. She should not go into hypoglycemia. She should not have glycemic variability, which means highs and lows. And obviously, she should not have hyperglycemia. Most importantly, she should not walk into ketosis. Now, this is very, very, very important. Today's date, I see a lot of young women come to me who are following a ketogenic diet, who walk into pregnancy, After walking into pregnancy, they do not want to give up on the ketogenic diet. They want to continue the ketogenic diet. Unfortunately, if the fetus is exposed to ketones, maternal ketones, the child is going to have issues with the neurodevelopment. With the neurons, there is going to be a problem. Apart from that, the blood-brain barrier crosses the ketones, cross the blood-brain barrier. And third important thing is, as there is an increase in ketones, there is increase in free fatty acids, and these free fatty acids increase the risk of hypertriglyceridemia in the mother, which in turn causes macrosomic baby. So there is so much to go with reference to carbohydrate in your diet. You cannot go less than 175 grams of carbohydrate per day. Either you take the IDF guideline, the Ministry of Health guideline, or the ADA guidelines. All of them tell us that you need a minimum of 175 grams of carbohydrate per day to prevent nutritional ketosis in a gestational diabetic mother. So now we have our goals. So what are the calories we are going to provide her? In the first trimester, in her case, we found that she came to us in the second trimester. So for first trimester, I ideally do not add on calories. I give usually 30 kilocalories per kg ideal body weight. Whatever is a pre-pregnancy ideal body weight, that I will multiply with 30. That is the requirement for the first trimester. Second trimester, what do? I add another 340 calories to the 30 kilocalories per kg IBW. Now, what do? Apart from the other macronutrients, I need to worry about protein. She needs to be given at least 71 grams protein throughout her pregnancy, whether it's first, second, or third trimester. The fat has to be healthy fat. The more the saturated fat in her diet, the more the trans fat in her diet, there is going to be a risk of increased TGL and increased risk of macrosomia. Fiber needs to be at least 28 grams. Now, when it comes to sodium, it is similar to a non-pregnant mother. Now, always remember, a pregnancy with hyperglycemia, she's at very, very high risk of pregnancy-induced hypertension. In this case, what do? Usually, these patients are put on aldactone, that is a diuretic, because this pregnancy-induced hypertension is more so hormonal. So you give the normal salt, but you do not add sodium-rich foods to her diet, because most pregnant mothers like to have raw mangoes with a lot of salt in it, or they may have some food cravings like pica, wherein they may choose on processed foods or extra sodium-rich foods. So she should keep away from extra sodium-rich foods. What about the other micronutrients? It's as usual. We follow the RDA, the ICMR, the folic acid, iron, calcium, vitamin C, and it's not rocket science for me to tell that you space the iron and calcium and you add the vitamin C with the iron. Now, this is based on all these guidelines. I've come to a calculation which requires almost 1,900 calories, at least 260 grams of carbohydrate, 70 grams of protein. Fat should be 60 grams, including both visible and invisible, 28 grams of fiber. Salt will be including both visible and invisible sodium. If you look at a food without adding salt to it, basically your fruits, vegetables, rice, pulses, greens will not cross 300 to 500 milligrams of sodium per day at all. So, minimum of 2.3 liters of fluid. Also remember that a GDM mother or a pregnancy with hyperglycemia, if she's not hydrating herself well enough, and if her sugars are not under control, she is at risk of urinary tract infection, which in turn is not going to do good during her pregnancy. Now, what should we do, with reference to the carbohydrates? In her case, we've chosen, her calculation tells us we need to give at least 261 grams of carbohydrate. And remember that a post-lunch and post-dinner both were raised. So what do? The guidelines do tell us that we need to split the breakfast. You take any guideline, it tells us you split the breakfast. Reason for splitting the breakfast is there is dawn phenomenon in a pregnant mother. What is dawn phenomenon? Basically, a pregnant mother with diabetes, we see insulin resistance is highest in the mornings. When it is highest in the mornings, what are we supposed to do? It is highest in the mornings because of increase in cortisol. There's an increase in cortisol, growth hormones, progesterone, catecholamines. All of them are on the high in the mornings. So there is an increase in the fasting blood glucose. Now, with the raise in the fasting blood glucose, if you're going to give a decent meal without insulin in her diet, without splitting the meal, the postprandial blood glucose is going to cross 120 milligrams. So the concept of split meal plan therapy came in. But now understand, with practice of about 30 years in the field of diabetes, I've handled a lot of GDM mothers, a lot of PCOS walking into GDM and then coming to me for weaning for their children. I have handled those who are on MNT, not only splitting breakfast, splitting lunch, splitting dinner. What am I doing by splitting? For example, if the patient is eating 4 chapatis for lunch, she's a pregnant mother, she's hungry, people around her are telling you're eating for 2 plus eat. So she is used to eating 4 fulkas, 4 small fulkas. Now, with her 4 small fulkas, her blood sugar is about 140 postprandial. If I'm going to bring down that 4 fulkas to 2 fulkas and gap of 2 hours and another 2 fulkas, I'm bringing down the carbohydrate from 68 grams to 34 grams. So obviously her postprandial blood glucose, which was 140, will come much below 120, and I can push her, as much as possible to be without insulin. But if required, if she needs to be on insulin, we have no choice because there is no harm with insulin. But at the same time, she will be away from those pricks, which she will get the discomfort because of insulin. But if you can manage to do it with split meal plan therapy, I've managed several patients, and not only me, even the theory tells us that 90% of the patients can be handled with MNT. But unfortunately, no textbook tells us that you can split lunch, you can split dinner. It is your common sense. You want to bring down the glycemic load of the meal. Automatically, the glycemic index of the meal also comes down. When you're splitting the load, obviously the postprandial response is much lower. When the postprandial response is lower, the next pre-meal also gets lower. So that's the best way of handling our blood sugar. The second thing is you need to concentrate on giving the food order. Choose the food order. First the fiber, then the protein, and then the carbohydrate. That way, that food order also delays the postprandial gastric emptying. The third thing is what sort of protein it should be. Lentil carb in the form of whole grams or sprouts, or it could be a raita from low fat milk. It could be nuts, which could be soaked, because only soaked nuts, they are more bioavailable in terms of zinc, protein, and apart from that, they are more easily digestible. So you can choose the protein, the healthy protein, prior to the meal. Now, this is the composition with reference to carbohydrate. How do we arrive at 50 to 55%? We have so many guidelines. One guideline tells us, the IDF MENA 2021 tells us 35 to 45%. There's another guideline telling us 35 to 50. Now, we have the government of India telling us 50 to 60. Now, where do we stand? We are so confused. What do we choose on? Do we choose on something like 35 to 50, which is very, very low in our Indian setup? In our Indian setup, we have enough studies, the Indian START study, the ICMR study recently, which was published on what India eats by ICMR 2020. All of it tells us that the carbohydrate consumption is between 70 to 75% in an Indian. So what do? We choose the government of India guidelines, which is 50 to 60%. It is still on the higher side. We are unable to achieve 35 to 50%. So what do? We go in between all these guidelines, choose between 50 to 55% and major section from complex carbs and high fiber. But at the end of the pregnancy, in the last trimester, just prior to delivery, you will see that the patient's blood sugar is continuously dipping. You'll be so confused. Was she a GDM? This tells us that she is nearing term. When her blood sugar start dipping, at the fag end of her pregnancy, this gives us a clue. If she's on insulin, then the insulin dosage comes down because the intake also gets compromised. Her intake gets compromised because of the large abdomen and decreased appetite, and some amount of GARD is also there during the last days. Now, this is the data which I was talking to you of. When you go on a very, very low carbohydrate diet, what really happens? There is an increase in maternal ketones, which impairs both fetal and postnatal neural development. There is an increased risk of macrosomia. There is also micronutrient deficiency. Also, the structure of the neuron gets affected. So, minimum 175 grams of carbohydrate. I have another 10 minutes. I'll quickly wind up the 3 cases. Now, this particular patient is on insulin, and she has a pre-pregnancy weight of 57. Her present body weight is 55. So she's lost weight. Just understand, she's lost weight after she has conceived. She has a height of 159, and she has classical symptoms of hyperemesis gravidarum, a condition which is characterized by severe nausea, vomiting, weight loss, and electrolyte disturbance. Her serum pregnancy test was positive in her first pregnancy. In her first trimester, her HbA1c was 5.7. So the question is, what should be our ideal blood glucose during pregnancy? And what would be the ideal advice you would give to somebody who's a GM on insulin and she's having symptoms of hyperemesis gravidarum? As I mentioned to you, she's having severe nausea, vomiting, she's on insulin. So she can walk into nutritional ketosis. So what do we do with her? And she has lost 2 kgs of weight in her first trimester. So all these reasons we have to keep in mind. So the target blood glucose range, as I mentioned to you, I want the fasting less than 90, postprandial less than 120. What is the time in range? Nowadays, you know that the AGP has been fixed for whether you're a type 2, type 1 or pregnancy. We have the AGP fixed. With the AGP, you look at the time in range, fix the goal. More than 70% should be between 63 to 140 milligrams. It should not cross it. Less than 63 should be less than 4% only, because there is a risk of losing the fetus when you are having hypoglycemia. Less than 54 milligrams should be less than 1%, which means we should not have hypo at all. And above 140 should be less than 25%. According to me, we should not have hyperglycemia at all. So what should be my goal as a dietitian? I should allow her to sip on electrolyte-rich food. So in her case, I may have to give her tender coconut water, buttermilk, rice porridge, or whatever porridge she wants to take, or an oral nutrition supplement given to her in the form of 50 grams of carbohydrate every 4 hours. In her case, if she's on insulin, it's not a worry. If she's not on insulin, I'll have to split the carbohydrate to 25 grams into 8 times a day, so that the glycemic load is on the lower side and she does not require insulin. If she's on insulin, it's no issue. I can give her as high as 50 grams of carbohydrate, one shot, and I can prevent starvation ketosis by providing at least 175 grams of carbohydrate per day. Now, next thing is the meal should contain at least 175 grams. So we go on a 6-day diet because she's on insulin. I don't have to worry. Hydrate her well, ensure that she's taking adequate sodium and potassium through fluids, and she does not get dehydrated. If she's a type 1, she can walk into diabetic ketoacidosis, which could be dangerous. So pregnancy in type 1, that's even more dangerous if she walks into hyperemesis gravidarum. Reason is hypoglycemic unawareness. She may not even know that she's in hypoglycemia. That could be even more dangerous. So as a nutritionist, you need to handhold her when she's especially on insulin. And suppose she's had a bad obstetric history, she has lost several, pregnancies, and this is a precious pregnancy. All pregnancies are precious, but this is a precious pregnancy which she's already had a history of BOH. So we need to be careful that she does not have hypoglycemic episodes because of hypoglycemic unawareness, because of autonomic neuropathy. They don't understand that they are having hypoglycemia. Now, this is another case which tells us that this is Mrs. CB, wherein she had chaotic blood sugar, fluctuation. She had readings as high as 195, below 70. Her 3 a.m. blood sugars at 3 a.m. was below 70. Though she was very meticulous in her meal plan and insulin regimen, but still this hyper and hypoglycemia was troubling her too much. And her diet history did reveal that she had an early dinner. She used to skip her bedtime snacks. She used to have a very disturbed sleep because midnight she used to have hunger pangs. She used to get up and eat 6 Mary biscuits till she satiated. Now remember, this particular patient is having an early dinner and she's skipping her bedtime snack. She's on insulin and she's having 70 milligrams of blood glucose midnight at 3 a.m. What does it tell us? It tells us that she's not had a bedtime snack. Always remember, any pregnant mother with diabetes, whether it's type 1 or type 2 or classical GDM, she needs to have an evening snack and a bedtime snack in order to prevent her from going into nocturnal hypoglycemia. So in her case, she is having Somiogi phenomenon. I'm not talking of dawn phenomenon. I'm talking of Somiogi phenomenon, which is very, very classical in a type 1. If she is on short-acting insulin for dinner time, does not take a bedtime snack, or she's on a very high dose of short-acting insulin, and she's taking a bedtime snack, but she's having nocturnal hypo, which she's trying to sort out. If she's unable to sort out on her own body produces glucagon, increases her fasting blood glucose, which causes Somiogi phenomenon's raise in blood glucose in the morning. So if you are going to give her a bedtime snack or adjust the dose of insulin, she will not have a nocturnal hypo. She will not consume those Mary biscuits or any other snack in the night. In case she's having hypoglycemia, she does not even realize. She may slip into coma, and early morning she can have hyperglycemia. So be very careful for those pregnant mothers. You need to give an evening and a bedtime snack. And remember, if she's on what type of insulin. Now, next, She has a lot of doubts on probiotic drinks because she thinks gut dysbiosis can be helped with probiotic drinks. Remember, the drinks which are available in the market, the probiotic drinks, contain from 2 teaspoons at least. I think about 7 grams is present in about 100 ml, in 66 ml of a probiotic drink. So depending on how much volume she consumes, the amount of sucrose keeps adding on. So probiotic drinks is a big no-no. Yes, you have probiotic yogurts which are available in the market. Instead of that, I would suggest to go on prebiotic foods which help to synthesize probiotics. But also there is a paper from CMC Vellore which does tell us that we can choose on little fermented curds, meaning the curd is already set, that is already fermented. It is again kept overnight. Now, how can you do this without it being very, very sour but behaving like a probiotic is you set the curds in a mud pot. When you set the curds in a mud pot, the temperature is between up to 11 to 18 degrees in the mud pot, and it does not get sour but behaves like a probiotic in nature. This was a paper from CMC Vellore. And her husband wanted to know if beverages with non-nutritive sweetener was a healthy choice during her pregnancy. So what is the answer? I have already made a mention to you that they are good. They help to reduce the incidence of GDM. They help to improve fasting insulin assay. They also are found that it improves both lipid and glucose metabolism in pregnant women. So pre and probiotic are good. But then there is a problem like temperature, anaerobic storage conditions, initial strain, its quality, dosage. All this is a big question mark. We do not have enough data to tell us which one specifically is ideal, in which strain, which quantity, which temperature, which storage will be ideal for a GDM mother. So it's better to choose on prebiotics like onion, garlic, leeks, and probiotic, which I mentioned to you, set your curds in mud pots. So what is the role of non-nutritive sweeteners? Sucralose and stevia are safest in pregnant women. We have some data to tell us for that. But saccharin crosses the placenta. There is not enough safety with reference to asulfame, potassium, and polyols. Polyols are sugar alcohols, which also can cause osmotic diarrhea in somebody with type 1 diabetes and pregnancy. With or without pregnancy, they can have diarrhea because of sugar alcohols. Now, there is some recent data to tell us that this was studied in about 103,000 population for about a period of 21 years in France, and the paper was published in 2022, according to which they found that aspartame, asulfame, potassium, and sucralose. With reference to pregnancy, I would say that sucralose is the safest, but that also it has to be consumed in ADI, but better avoided. The reason being, it can cause gut dysbiosis. So better avoid it. Second thing is gut dysbiosis increases insulin resistance and worsens blood sugar control. Third important thing is there is an increased risk of cardiovascular disease for those who are on sucralose for long term. So it's a big no when it comes to non-nutritive sweeteners. Now there is some more questioning and answering going on with somebody who's in a third trimester. She wants to know, she's having bilateral pitting edema with PIH. She's on aldactone. She's having anemia. She has few queries. Can she take some red wine? So she heard that it helps to improve hypertension. We have to understand that red wine has percentage of alcohol in it. From as low as 3% to as high as 23% of alcohol is present in red wine. Second thing is, on an average, any red wine bottle contains at least 12% of alcohol. So any amount of alcohol consumed during pregnancy is a big no-no, because it can cause a risk of preterm delivery, low birth weight, and also facial abnormalities in the fetus. And even after birth, they would find that the child is having behavioral disorders or impaired intellectual development, or the CNS is impaired, growth deficiencies, birth defects, the list just goes on. You can also have a floppy baby, also have fetal alcohol syndrome during the pregnancy. So it's a better to avoid even if it is red wine. You can get polyphenols from green tea, from green leafy vegetables, and the list just goes on. Would a salt restricted diet help? I think I've already made a mention that we don't need to go salt restriction, but we need to go sodium restriction. Extra sodium rich foods need to be avoided. Now, is there a difference whether I follow a DASH diet during pregnancy? Will it help me? There was a RCT, a systemic review with 19 trials done, wherein they found low GI, low GL, low fat, high fat, healthy fat, low unsaturated fat. They found some different permutations and combinations, and at the end of the day found that when they followed a DASH diet, the only difference was those patients had a 47% relative reduction in the risk of a cesarean birth. That was the only difference when they followed a DASH diet during pregnancy. So what about consumption of dates? I think as nutritionists, all of you know that fresh dates, they are not a source of iron. They have less than 1 milligram of iron per 100 grams. A lot of patients consume dates for the iron. It's only the dried dates which have more than 4 milligrams of iron per 100 grams, and you and me cannot consume 100 grams. So it's out of question. You can think of other alternates like drumstick leaves, roasted Bengal gram, rajma, black chana, all these sources for your iron. That is the vegetarian sources and the healthy sources. Now, when it comes to dates, always remember they have recently had the fortune to publish a paper with Dr. Anup Mishra, wherein we did a lot of study on dates and found that their GI ranges from as low as 53 to as high as 74. And also the stage of dates, there is various stages of dates, are there semi-ripe, fully ripe, calmer stage, all these stages, they have different GIs. And we cannot identify which stage the particular date is. So dates are of no use. I think as dietitians, you are aware that what sort of sources of iron, B12, folic acid, and protein can be provided to prevent anemia along with vitamin C. Now, when it comes to adjunct therapies, can the pregnant mother take adjunct therapies? Because she was taking flax seeds, chia seeds, we're in a world of seeds, nuts, and oil seeds during, pre-pregnancy period for health reasons. But there is evidence to tell us that from Mayo Clinic that nuts and oil seeds like flaxseed, hemp seed, pumpkin, poppy, chia, oregano, rosemary, all these should not be consumed as adjunct therapy during pregnancy. Now, fruit, can the pregnant mother take fruit? Yes, she can take fruit. When does she take a fruit? In between her meal. Best would be evening or bedtime. And avoid fruits in the mid-morning or during breakfast unless she's having hyperemesis gravidum or morning sickness. Otherwise, you will not allow your pregnant mother to take fruits in the mid-morning or breakfast. It's always evening or bedtime, never along with the meal. Ensure that a fasting is less than 90, postprandial less than 120. Only then you'll allow her fruits. Best fruit will be a guava or citrus fruits, which are really low in GI and GL. The avoided ones are tender coconut, banana, jackfruit, processed dates, raisins, raw papayas. So then this is the last case, and I think I'm just in time. Now she's already delivered. She had neonatal hypoglycemia. That is the baby which was born had neonatal hypoglycemia, which is one of the complications of GDM mothers. She started breastfeeding after 16 hours. Now her complaint was she had complaints of inadequate feeds, frequent complaints of being tired, severe headache after nursing the baby. She was reluctant to continue breastfeeding within 5 weeks. She had erratic blood sugar control from 250, as I had 250 to the time in range being worst, that is 50%. As a nutritionist, what would you tell her? We would tell her to continue breastfeeding because that's the best vaccine she can provide to the baby. Second thing is she needs to take at least one carbohydrate count prior to her nursing the baby in order to keep her away from hypoglycemia. That is why she's having a headache and she's tired after nursing the baby. Third thing is she's not adequately nourishing herself in terms of quality diet. Fourth thing is she's not adequately hydrating herself. That is why there could be probably inadequate feeds. And eating pattern is erratic. Usually it is difficult to achieve good glycemic control in the initial first 1 month of, lactation. But eventually you do, manage to get good blood sugar control. It's only the lactogogues, the healthy lactogogues, which you need to choose on, along with a healthy diet, not a high saturated fat diet, which is in the form of laddus and stuff like that, which is provided to pregnant mothers after delivery. I think I'm through. And most importantly, what type of carbohydrate would you choose, which has a second meal effect? It's all the lentil carbs, which you need to choose. The lentil carbs are the oats, the whole grams, which help to improve the postprandial blood glucose. That is the barley. They move inch by inch. They also behave like prebiotic. They help in gut dysbiosis, as well as they delay the gastric emptying and provide satiety, good glycemic control. So thank you so much for your patient listening. And before I end, I would want to share this, that a big thank you to Salome ma'am, who's been a part of my journey of nutrition as a nutrition therapist, because I'm totally inspired by her. And even now the greed is there to get trained by her. So I acknowledge ma'am in my 2 lives twice as precious as an inspiration from Salome Benjamin ma'am. And definitely I need to thank Dr. Geeta Dharmati also for a treasured message for 2 lives twice as precious. Thank you for your patient listening.
Thank you. Thank you, Meenakshi. I think we have no words. You have really done your job thoroughly and we appreciate. And thank you for your appreciation. I am really, what I should say that it's a, I mean, it's privilege or it's an honor from a 30 years experienced dietitian and leading dietitian like you to acknowledge. I am thankful for your acknowledgement. And
Thank you so much. You're a true inspiration for all of us.
thank you. Thank you again. And thank you for being on BNA Live platform. And today, really, you have enlightened all our participants in this particular scenario where so many errors are being made by so many dietitians. So I am really thank you. And we would request you to be on the scene as there are so many questions. Nazneen, quickly, some few important questions if we can take.
Sure, ma'am. Meenakshi, first of all, congratulations, fantastic talk. And you covered so many things in this short span. We really, really appreciate. Okay, so there are a whole lot of questions, and I'm going to take some relevant
important,
ones. So
yes.
somebody asked, Sangeeta asked about seed cycling and how it can help in PCOD. Along with that, there are also questions that first of all, before we come to that, for girls who don't have periodic cycles, how do you actually calculate? So we'll take the second question first.
No. What do you mean by how do you calculate what?
So if she's getting her periods once in only 3 to 4 months, how do you calculate her first 14 days and 15 to 28 days to start seed cycle?
Say, for example, somebody has just had her cycle on the first of her month. Okay, first of this month, she is a PCOS. She's having irregular menstrual cycles. End of the day, she's getting a cycle, right? It could be after 2 months, after 3 months, after 4 months. She's getting a cycle. After she has got her cycle on the first of this month, so from first to the first till the 14th, it is the first 14 days. It is considered as a follicular phase. Whether she's folliculating or no, immaterial of that, we take it as the first 14 days and she continues 1 tablespoon of flaxseed and 1 tablespoon of pumpkin seeds for the first 14 days. The next 15 to 28 days, immaterial whether she gets her cycle on the 20th day, 30th day or no, she will take for the next 14 days 1 tablespoon of sunflower seeds and 1 tablespoon of sesame seeds. But she has to go in combination with fish oil, with vitamin D, with myo-inositol. Usually, when I work with the gynecologist, she puts them on myo-inositol and all these nutrition supplements, and I take care of the seed cycling. Along with the seed cycling, I take care of her diet. Now, how does it work? If you want me to make a mention of it is, they usually work with the presence of zinc in the pumpkin seeds, which prevents the estrogen from converting to harmful form of testosterone and also prime the body for progesterone production. So progesterone is on the low. That is why the luteinizing hormone is also dipped and ovulation is not happening. If progesterone was adequately produced, then she would ovulate on time. So this is the zinc which does an important role, which is present not only in pumpkin seeds, you can also choose on whole grams, especially the sprouted whole grams. You can choose also on nuts, which can be soaked overnight and consumed. So it's a source of zinc, which is from there. Second thing is when you combine both sunflower seeds and sesame seeds also, that is in the luteal phase. That is in the second cycle. You will find that it has a much lighter dose of lignans from the sesame seeds, but it is once again a source of zinc and selenium, which again helps in progesterone production. Apart from that, we know the flax seeds are anti-inflammatory in the form of omega-3 fatty acids. So this is how they work along to have a balance between both progesterone and estrogen. Not only that, the flax seeds mainly, they bind to the excess estrogen and help the body to eliminate it. So when the estrogen is peaking without adequate progesterone, also there is hormonal imbalance. And with testosterone, we'll have to worry with green tea. We'll have to worry with, going vegan if possible, plant-based, even if that's possible.
Thank you, Meenakshi, for that elaborate answer. There are also questions by Priyanka Chaudhary on can PCOS patients take egg yolk and dry fruits, and also any specific fruits and vegetables to be restricted.
Okay, the first thing is when it comes to egg yolk, I would still say go plant-based. If you cannot go plant-based, you still want to hold on to eggs, hold on to the egg white, not the egg yolk. Though we know that the table eggs or the layer eggs, they are not those eggs which can, deliver chicks. It's like, how do I explain to you? They are not those, they call them broiler eggs, okay? In layman's language, people call them as broiler eggs. There is nothing called broiler egg at all. The ones which come on our table, they are known as table eggs or layer eggs, and they cannot reproduce further. So, but egg yolk is a source of saturated fat, which in turn can cause gut dysbiosis. So that is why we do not want the egg yolk. Otherwise, it's not the hormone which is going to be troubled at all. But chicken, yes, you know very well, broiler chickens are available in the market and hormones and stuff like that. So that is why we want them to go plant-based. When it comes to dry foods, nothing like almonds soaked, because the carb count is 0 when it comes to 1 serving of almonds. And walnuts, nothing like, omega-3 fatty acids, but you need to count them in the form of calories. You cannot just say that I'm going to take already a 1,200 calorie diet and I take a serving of almonds in the morning, a serving of walnuts for lunch, and again a mixed source of nuts, almonds and hazelnuts and pine nuts for dinner. You need to count them as calories. So you deduct the calories. Third thing, when it comes to fruits, ideal will be the citrus fruits, which are absolutely low in GIGL, and vitamin C has an important role to play to prevent preterm labor. All these precious pregnancy, there is a risk of preterm labor. So we need a source of vitamin C coming from guava and citrus fruits and avla. Apart from that, vegetables, yes, go on low GI, low GL, whatever said and done, potatoes, keep a little off from potatoes. If you really want to have potatoes, then squeeze the potatoes with a lot of lime on it, so that it behaves like a resistant starch. But I would still say go low on it.
Sweet potato we can have.
Yeah, you can have sweet potato boiled and squeeze some lime over it. Even that, squeeze some lime over it.
Okay. Also, thanks, Meenakshi. There's a question from Deepali, and she's asking, what is the formula being used for fluid requirements?
Fluid requirement, this is not a formula which I used. Ideally, we use formulas only in critically ill or in renal failure patients, where we'll say urine output and plus 500 or whatever, 750 ml, whatever. It's different for critically ill and renal failure. In this recommendation was provided by IDF 2021. So I went with the formula, no formula, 2.3 liters was mentioned by IDF 2021. That's the minimum.
Okay. We also have a question by Madhvi Kumari. Although you've answered it, you can just answer a question again. She's asked about nutritional supplements for insulin resistance and PCOS.
Yeah, one is vitamin D, second is calcium, third is myo-inositol. So she needs to be on all of this. And N-acetylcysteine, NAC.
Meenakshi, I have a supporting question here. You mentioned about spirulina and lot of importance to spirulina, and you did mention 6 capsules of spirulina.
6 tablets.
6 tablets.
I believe I have seen lot of patients whom actually I did a lot of study for Paris who produced spirulina. It so happened during that process, I did a lot of deep diving and I used it for so many of my PCOS patients. Not only PCOS, type 2 DM, pre-DM patients, wherein I have found good blood glucose control. Basically, it helps in gut dysbiosis. That is point number 1. Apart from that, B12 also.
So how much is 6 tablets
6
coming
tablets a day. 2 in the morning, 2 for lunch, 2 for dinner. No, I'm not sure.
Spirulina differs from brand to brand.
I'm sorry. To be very honest, though, I'm not a promoter of Pari here, but I've seen their factory and stuff like that. So when I prescribe, it's only Pari. I do not know. There are so many companies providing spirulina. So safety wise, I have only seen the research behind Pari. They do umpteen research. They don't come out with any prescription just like that. And it so happened that we did a study in their population who had PCOS. A lot of their company employees who had PCOS. So we gave them 6 tablets and then came to a conclusion, yes, they get pregnant and stuff like that. And also tried in other patients apart from the Pari company. I've seen excellent results with spirulina, but only Pari company. I've not used any other product. It's unfortunate that I'm making a mention of a brand name here.
I think, Meenakshi, thank you so much. And I think there's some fabulous comments coming in, and you actually spoke like a talking
expert.
Expert.
I think I was very fast, but I didn't know what to stop.
There's so much of information. I think we needed to have a workshop of 2-3 hours of only case-based discussions, because your book has everything what you spoke. And I think that needs a lot of deliberation, brainstorming. And with Salome ma'am in picture, I think we'll have a lot of discussions also post session. So that's, I think, ma'am, please take a note that we need 2-3 hours of sessions with
Yes,
Meenakshi.
I agree with you. I agree with you. But Meenakshi, you must catch hold of her. She's very busy.
No, ma'am. No,
You
I'm
must
not
do
busy.
it in Chennai, Mumbai. I think specifically in this area, we are having lot of, what
Confusion
I
and-
should say. Yes, I know. I mean, it's myths, so many myths, and so many errors we make and we lose on these precious patients. So I want our girls to be, really expert like Meenakshi. So we will
I
do
think it's
it
an
in
honor to
Meenakshi.
hear this from you, ma'am. It's like a blessing in disguise.
So we'll do it jointly together. Geeta is there with nutrigenomics, with so many other things, and with lifestyle. Nazneen is there, and we are there for clinical. So we can
And I think
combinedly
yoga
do
also
it.
plays an important role. I didn't touch on yoga. I think Nazneen is an expert with reference to
Exercise.
yoga and PCOS. There's a lot to do with yoga and PCOS.
Yeah,
I didn't
it
touch
was
on that
beyond
because
your talk
no
today. It
time.
was beyond your talk, the exercise, but it is also an important factor which we will take it in another session. Thank you so much. And I think we all appreciate for your time and for the knowledge and for the evidence given to us. And I think there are some
Yeah, they can
pregnant
mail to me,
mothers.
they can WhatsApp to me, so I will respond to them. Not a worry.
Yes, thank you. There are people who have joined who are really interested in this session and they have been benefited. So I am thank you. Thank you,
Thank you, ma'am.
Meenakshi.
So for
Thank you.
all
Thank
of
you,
you,
Nazneen.
just
And a vote of thanks from
it. This
Geeta
is
or Nazneen. Whoever.
on all BNA Live, social media channels. You can catch it. It will get live on the YouTube channel of BNA Live. We have a very, very active website now. We have a lot of social media posts. So just in case for those who have joined this for the first time, please go ahead, give it a big like today's session. Also give us some suggestions on what are some of the things which you would like to learn, and we for sure will take this as a part of BNA Live. We have under Salome ma'am's leadership, we're trying to cover the most relevant topics, ably supported by Dr. Geeta, Richa Shukla, and Nutritionists. We have Mr. Gandhi, who's been like the backbone for this entire event. So, and we've had a lot of friends from the nutrition industry. We just heard a brilliant talk by Meenakshi. So we look forward to all of you all joining in. And thanks, Meenakshi. We're going to catch hold of you once more time. This 1 hour was not enough.
Nazneen, tell
No,
all the
we're still
participants to listen to the video again on the YouTube. I think it is worth listening again and again.
Correct.
Today's talk.
Everybody needs to go back and capture, because Meenakshi gave not only clinical nutrition but human nutrition, food science, all of that packaged in this 1 hour. So thanks, Meenakshi, for all that brilliance.
Fantastic.
Yeah, and all of y'all need to definitely go and look at our YouTube channel, give it a lot of likes so that it inspires us to do more and more better work. Yeah.
Correct.
The Gandhi and team have also uploaded a whole lot of research journals, and we are trying to create a resource library for all of you all for quick references. It will take you to landing pages of many international journals where you can easily go and research as well. So please ensure that you're also going and visiting all these websites of BNA Life. Yeah. Thank you so much and have a great day.
Thank you. Thank you very much.
Thanks,
Thank you.
Thank
you. Thank you, ma'am. Thank you. It was wonderful.
Thank you, all of you.
Thank you, Meenakshi.
Thank you,
Thank you very much,
Geeta. Get
Geeta,
well
ma'am.
soon.
Bye, Nazneen. Thank you so
Thank
much.
you, Saloni, ma'am.
Meenakshi,
Thank you, ma'am.
all.
Thank you, Nazneen, ma'am.
See you
Thank you
soon,
very
all.
much.
Sorry, it was Eid. Everything got delayed. Bye.
And have a nice
Bye.
Eid.
Thank
Nazneen, celebrate your Eid.
Yes,
Thank you.
Nazneen.
Thanks. Bye.
Bye.
Great. Geeta, ma'am, please take care. Yes.
Doing better already.
Yes.
Back soon. Thank you.
Yes. Thank you. Bye-bye.
এখন যে স্টেনলেস স্টিল হাড়ি তখন ট্রেন মানে বড় জিনিস ভারী এগুলো, কিন্তু স্টেনলেস স্টিল আমাদের ইয়েতে একটু বেশি ভারী, তার তুলনায় অ্যালুমিনিয়াম স্টিল একটু বেশি হালকা হয়। এখন যে অ্যালুমিনিয়াম স্টিল ওগুলা হালকা, আর অ্যালুমিনিয়াম স্টিল মানে তৈরি করা মানে ট্রেন তৈরি করা হয় যেটা ফাস্ট, মানে যেটা বুলেট ট্রেন বা এই যে সিগন্যাল স্পিড দিয়ে ট্রেন গুলা এগুলার জন্য, যাতে তাড়াতাড়ি যেতে পারে দৌড়াদৌড়ি। এবারে তার যে সাথে যে বডিটা ওগুলা বেশি বানানো হয় টাইটেনিয়াম